Welcome to Cancer Newsline, a podcast series from the University of Texas MD Anderson Cancer Center. Cancer Newsline helps you stay current with the news on cancer research, diagnosis, treatment, and prevention, providing the latest information on reducing your family's cancer risk. I'm your host, Dr. Ed Kim. Today we're talking with Dr. Patrick Hu, Chair, Department of Melanoma Medical Oncology, and Dr. Beth Mittendorf, Assistant Professor in the Department of Surgical Oncology. Today we're going to talk about immunotherapy and some new data that has come out regarding breast cancer, but we know this field has really covered many different tumor types. And I know patients come and see me and they ask, well, what can we have as far as vaccines? Don't those make the most sense? Don't those cover us and help prevent and not only treat cancers? And disappointingly, I have to tell them many times, we don't have anything right now in the clinic that's applicable, at least in lung cancer, but it's a fascinating area. We know that body's immune system is something that can help us fight. This data that's going to be presented at an upcoming meeting, Dr. Mittendorf, seems very promising. I wonder if you could give us an overview on that.
Sure. So the data that we'll be presenting at the upcoming ASCO meeting is preliminary data from an ongoing phase 2 trial that's looking at a vaccine administered to breast cancer patients. And the thing that's noticeable about this is it's being administered in the adjuvant setting. So after a patient has completed all of their standard of care therapy and rendered free of all of their disease, we're giving them the vaccine in the hopes that by educating their immune system, we could delay any recurrent events or perhaps even prevent disease recurrence. And so the trial has enrolled patients who have node-positive or what we would define as high-risk node-negative breast cancer. And they can have any degree of HER2 expression on their tumor. And this is an important distinction because when we think about HER2-positive breast cancer, we consider patients who are going to benefit from the drug trastuzumab. And in order to benefit from trastuzumab, patients have to have a lot of the HER2 on their cell surface. About 25% of breast cancer patients meet that criteria. But for this vaccine approach, patients can have any degree of HER2 expression. So that expands the number of patients who may benefit from vaccination to about 70%. So patients were administered the vaccine. It's given just under the skin once a month for 6 months. After they complete that series, they then get a booster inoculation, much like we would see in an infectious disease model, like a tetanus booster, once every 6 months for 3 years. And then we're following the patients to look for disease recurrence. And the data that we're going to be presenting is looking after a follow-up period of 22 months, and it shows that there is a decrease in the rate of recurrence for those who received the vaccine compared to patients who received a placebo inoculation.
And in this setting of patients where they're cured and we're told, my gosh, you're doing well. Usually it's a discussion of which hormone therapy and which pill they're going to take. Is this something that causes a lot of side effects, or is it pretty easy to take?
It's very well tolerated, and I think that's why the patients have a lot of enthusiasm for it. And actually, as an investigator, that's why I initially had enthusiasm for it. This is something that we're administering after completion of standard of care therapy, so we're not suggesting the vaccine will replace chemotherapy or replace radiation. When patients get the shot, most of them do have a little bit of redness at the injection site. The majority of them have a very short-lived period during which they have flu-like symptoms, feel a little bit achy. It seems to be resolved with Tylenol. But other than that, it's been incredibly well tolerated. And so the thought is that if you can get any benefit with such little toxicity, that's something that's appealing to both myself as the investigator and the patients. But with respect to your comment about endocrine therapy, clearly in breast cancer, that's a very important component of their care. So patients on our trial who have the estrogen or progesterone receptor on their tumors do continue to receive their hormonal therapy pill, as is standard practice, throughout the duration of the vaccine series.
So Patrick, melanoma is probably one of the tumors that has really seen the gamut of immune modulation and has really tested this. From your vast experience studying this for decades and now seeing where we are today, how does this compare with the early treatments for melanoma and now to what we have you've seen in this type of data?
Well, the melanoma is interesting in that it's already trying to stimulate the immune system, so it's very immunogenic. So we've studied a lot of immune therapies with melanoma. However, we're finding now that other cancer types are immunogenic as well. And I think that immunology will be helpful to almost any kind of cancer. So this is a nice example of how vaccines may be helpful with breast cancer. We've performed vaccines like this in melanoma patients, and we're trying to optimize these vaccines all the time. There are many ways to stimulate the body's immune system. Vaccines are one method. Other methods are antibodies to take the brakes off the immune system, and others are using cytokines. Our feeling in the melanoma field right now is that combining these areas and combining these different approaches may be optimal. For example, we had a study that was published last year looking at vaccines in melanoma plus interleukin-2, a cytokine that helps to stimulate T-cell proliferation compared to the interleukin-2 by itself. And the combination increased the response rate in a randomized study. So I think I would predict that this is a really nice result that Dr. Middendorf has, and that it'll even be strengthened further with the combination with other kinds of therapeutics, such as cytokines or antibodies that take the brake off the immune system. This has been a very important field, this new field of checkpoint blockade. Let me explain that to you. Our immune systems can be quite dangerous to us. The immune cells are like little tanks circulating throughout the body, meant to kill bacteria and viruses, and we're, of course, trying to stimulate them to kill tumors. But left unchecked, we could get a lot of diseases such as autoimmune disease. So the body has natural braking mechanisms on all of our immune cells. And we're starting to learn what those brakes are and developing antibodies to block those brakes. One of these is called CTLA4, a brake that turns immune cells off. This was research done by Dr. Jim Allison. And if you take that brake off, you then allow the immune cells to kill cancer better, and that antibody was approved last year for metastatic melanoma. And we use it every day in the clinic now. Other antibodies along these lines include anti-PD-1, anti-PD-L1 antibodies. And these are have been effective not only in melanoma but other kinds of cancers as well, such as lung cancer. So we're real excited now that we think that the immune response is going to be important not just for melanoma but also for breast cancer, lung cancer, colon cancer, and other cancers.
It's certainly an area that seems to be better utilized, and more recently, I know questions that viewers who are listening would have is they're used to hearing about anti-HER2 therapy in breast, and it's been long documented how effective it is. You discussed that this would not interfere or even replace any current therapies that would be used in the curative setting. Could they be used on top to help synergize or complement? Is more better in this situation?
Yeah, that's an outstanding question and an area of active investigation for our group. Very briefly, we think that our data is showing that patients with the lower expression, the 1+, 2+, who don't benefit from the trastuzumab, are seeing benefit from the vaccine alone. And in fact, in a phase 2 trial that we've recently finished looking at a different HER2-derived peptide vaccine, something now called Nuvax, we again showed that the patients with the low expression did well with the vaccine, and that's the population that is currently being studied in a phase 3 trial. But we had generated some data in the laboratory to suggest that for patients who have the highest expression of HER2, if you use the combination as you suggested, so give them the trastuzumab and the vaccine, that will actually augment the response. And so when we went back and looked at patients who'd enrolled in our trials, and these were data that we presented at last year's ASCO meeting, we found small numbers, but 30 patients who had received trastuzumab as standard of care therapy because they were HER2 3+. None of those patients got the vaccine, and the recurrence rate was exactly what we would have anticipated, about 12.5%. We had 32 patients who were HER2 3+, so got trastuzumab of standard of care, and then received the vaccine, and no recurrences in that group. 1 year later, still no recurrences in that group. So at MD Anderson, we're currently conducting a phase 1 trial looking at the combination. We've completed enrollment in the highest dose cohort and now need to enroll 6 additional patients in an expansion cohort. And we've already designed a phase 2 trial that's going to be supported by Genentech looking at this question of the benefit of combination immunotherapy.
I mean, I think what we've learned from the melanoma side is that these combinations can certainly be beneficial and used to augment other effects as well as complementary to the curative therapies. Patrick?
Yes, it makes a lot of sense that an antibody plus a vaccine that's trying to trigger T cells would complement each other very highly. It makes a lot of theoretical sense. And so I would predict that that would work better.
What about some of these other tumor types? I know everyone seems geared toward testing in breast cancer, but we do know that HER2 exists, especially at some lower levels in other tumor types, such as lung cancer even, or salivary gland cancers or others. Have there been any investigations to expand those types of populations?
So some of the earliest trials with one of the HER2-derived peptide vaccines were conducted actually in ovarian cancer patients. The most studied HER2-derived peptide was actually first found in ovarian cancer. There's been an early study looking in bladder cancer, but those were, again, just early phase trials. There is an active interest in an international trial looking at a HER2-derived peptide vaccine in gastric cancer. So there is a growing interest in perhaps using HER2 peptide vaccines in other disease sites.
There's no reason why it wouldn't work on any kind of cancer that has HER2 expression.
Right.
But plus, I think the low level of expression can be recognized by an immune cell. So I think that T cells can recognize very low levels of antigen expression. So even that may explain why you got good results with patients even with low levels of HER2 expression.
And that also speaks to the fact that some of these other disease sites that you've identified, which haven't responded to Herceptin, may respond to a vaccine.
The other thing is there's a lot of evidence now in experimental models that if you just start the immune response against one antigen, it can then spread against many other antigens. We call that antigen spreading. So it's possible that you'll be able to get an immune response started against HER2, but then spread that response against many other antigens. And some of those antigens look like they may be mutated peptides. So we know that cancer cells have many mutations in them. That's what drives the cancer cell to be a cancer. Those mutations may be the most immunogenic antigens of all. They may be the best vaccines in the end. And so by stimulating a immune response against HER2, you may be stimulating a subsequent immune responses against some of these mutated peptides from the genes that are mutated in breast cancers and other cancers.
Well, you took my last question, and that was, Patrick, it was going to be, is this really targeted therapy, or are we really defining something different that the public can relate to and that patients can relate to that is not really a target-specific, but is now more of a system-specific modulation occurring?
I think we just have to get the fire started. We have to get the immunology fire started. And if you start that with a HER2 vaccine or a GP100 vaccine in melanoma or a vaccine against any particular antigen, you can just get the immune system kicked off to recognize all of the other proteins that are abnormal in the cancer cell. So I think it will potentially have relevance for almost any kind of cancer, vaccines and the use of these immunomodulatory antibodies. And I think we're talking about combined immunotherapies. That's really important. But the other combination that's important is now with all the targeted therapies. I think we have to learn how to rationally combine the targeted therapies with the immunotherapies. These are traditionally two separate silos of science, and we now need to try to bring those together to bring these two therapeutics together. I think we'll get optimal patient benefit with that.
Yeah, completely agree. And last thought, Dr. Mittendorf, what does this mean to the breast cancer patient now who's listening to this, or somebody who has a friend or relative who's diagnosed with breast cancer? What should they do with this information?
What I would recommend to patients, in fact, do recommend to my patients, is that they consider enrolling onto clinical trials in general, but specifically for patients who have a fairly good prognosis breast cancer who are looking for something to do other than the watch and wait to see if something comes back. That consideration for enrollment on a vaccine trial may provide them an opportunity to get a non-toxic therapy that may have some clinical benefit.
Yeah, and I think those are the types of therapies that really patients and physicians are looking for, is that something that's easy to take, that will help one be proactive in managing their disease or at least preventing their disease. And we know that these are young women who are being affected, and so I know many of them who are listening are going to be very proactive about this. And I think it's very exciting. So I thank you both for being here today to discuss this topic. I think it's a timely topic, and certainly there'll be more information coming out, and look forward to that at the ASCO meeting. If you have any questions about anything you've heard today on Cancer Newsline, contact Ask MD Anderson at 1-877-MDA-6789 or online at www.mdanderson.org/ask. Thank you for listening to this episode of Cancer Newsline. Tune in for the next podcast in our series.